Chapter 22, Care of Patients with Head and Spinal Cord Injuries. Lesson 22.1, Care of Patients with Head and Spinal Cord Injuries, Theory Objectives. Describe the types of injuries that result from head trauma. Compare and contrast the signs and symptoms of subdural hematoma and epidural hematoma. Explain why an epidural hematoma causes an emergency situation. Determine appropriate nursing assessment for a patient with a subarachnoid hemorrhage or an intracerebral bleed. Illustrate the pathophysiology of increasing intracranial pressure in a patient who has experienced a severe head injury. Review the reasons why an older person is more at risk for an intracranial bleed from a head injury. Explain the possible ramifications of a spinal cord injury. Plan appropriate nursing interventions necessary to provide comprehensive care for a patient who has sustained a C5 spinal cord injury. And analyze and review the symptoms of low back pain and correlate them with their causes. Clinical practice objectives. Teach a family member how to properly assess and care for a patient who has sustained a concussion. Perform a neurologic check on a patient who has sustained head trauma. Participate in a collaborative care planning conference for a patient who has sustained a spinal cord injury. Prepare a plan for teaching self-care measures to a patient who has low back pain. And participate in a collaborative care planning conference for a patient who has sustained a spinal cord injury. Traumatic brain or head injuries. Etiology. The most common modes of injury are going to be falls, being struck by an object like blunt force trauma, or motor vehicle crashes. Pathophysiology. The clinical symptoms observed in a concussion are thought to reflect a disturbance in function rather than a structural injury. Headache, balance problems, dizziness, nausea or vomiting, confusion or memory problems, feeling sluggish, hazy, foggy, or groggy are the signs and symptoms of a traumatic brain injury. Here are some examples of hematomas. In the first picture, you'll see a subdural hematoma. This means it is below the dura. In the next, B, you will see an epidural hematoma. Note that it is between the space, in the epidural space, matter of fact, between the dura and the rest of the body. Epidural hematoma is the result of a head injury that tears a large meningeal artery and has caused a rapid bleed with a large amount of blood above the dura. And in C, you have an intracerebral hematoma. Intracerebral hematomas are small vessels within the brain tearing and bleeding. Treatment for traumatic brain injury. Rest and sleep allow the brain to heal. It is a myth that sleeping after a concussion increases the risk of brain damage. Gradually resume normal activity. Patients are instructed to contact their healthcare provider if they do not feel back to normal within 1 week. EEG, or electroencephalography. This is a study where multiple electrodes are placed on the head with paste. Sometimes we place a stockinette or some kind of hosiery over the head of the patient. The patient can sleep through this test. The patient can also have it done when they're awake. We're looking for electrical activity in the brain that may be abnormal or concerning. Epilepsy and such can be diagnosed with an EEG. Magnetic resonance imaging, this is a midline sagittal view of the brain. Magnetic resonance imaging are going to give us a better view of soft tissues inside of the cranium and help us to visualize what is going on inside of the brain. This will also help us visualize swelling. Audience response question 1. The nurse is admitting a patient with a possible paraorbital fracture. Which clinical findings would likely confirm the diagnosis? Battle sign, partial blindness, otorrhea, rhinorrhea, or swallowing difficulty. Take a moment and determine what your response will be. Correct answers are battle sign, otorrhea, and rhinorrhea. Skull fracture. Skull fracture is characterized by the location, appearance, and degree of compression, and if it provides direct access to the sinuses, the oropharynx, the ear, or the skull through a skin wound. Fractures that do not cause bone displacement are left to heal, and we do not treat them other than what might be needed for injury to the brain. And surgical intervention is required to remove bone fragments and to prevent further brain injury from bone. Bleeding. Contusion can cause bleeding, a subdural hematoma, an epidural hematoma, a subarachnoid hemorrhage, and an intracerebral hematoma are all types of bleeding inside of the brain. The outward symptoms of scalp injury. They include bruising, swelling, lacerations, bleeding. The actual damage to the underlying brain tissue is not as easy to identify, and it needs to be assessed carefully, such as symptoms of amnesia, headache, decreased level of consciousness, or hemiplegia and ipsilateral pupil dilation. Skull fracture treatment. We will do a surgical debridement if needed. Additionally, measures to prevent increased intracranial pressure will be implemented. A patent airway must be secured, and the head of the bed must be raised 20 to 30 degrees with the body in correct alignment. Neurologic signs are monitored very closely, and an IV line is inserted. Diuretics are used to decrease vascular volume and to keep the intracranial pressure as low as possible. Preoperative period, brain bleeds require immediate surgery. So if you have a subdural hematoma, that's going to happen with head injury, like a blow to the head, right? It's going to rupture blood vessels that are between the arachnoid membrane and that tough fibrous dura mater. As the blood leaks underneath the dura, so it's a subdural hematoma, right? The hematoma gets larger and it presses against that brain tissue, and it can cause venous bleeding, and it may take time to for it to bleed enough to cause any changes in the ICP. It's a very slow bleed. Epidural hematomas, however, are going to be extremely rare, but when they happen, there is a rapid leakage of blood. And it's going to come from the middle meningeal artery. Sometimes it can come from other vessels, but most often the meningeal artery. And it's going to bleed into the space between the dura and the skull, which quickly will elevate that intracranial pressure. And that will constitute a medical emergency. Why is an epidural hematoma an emergency, whereas the subdural hematoma may not be? The difference is how quickly there is a change in intracranial pressure. If the intracranial pressure rises quickly because of a large bleed, then we're going to have a greater concern for brain injury. A subarachnoid hemorrhage can also occur. Usually traumatic brain injury can cause these just as the other two. The subarachnoid space is where the cerebrospinal fluid circulates. And so bleeding to that area circulates the blood throughout the spinal dural sac, and it predisposes the patient to developing things like hydrocephalus or water on the brain. Bleeding into the subarachnoid space is evidenced by a nuchal rigidity or a neck pain when they flex their neck. Intracerebral hematomas occur in the brain from traumatic blows to the head, non-force trauma, and that bleeding occurs in brain tissue and not within the meningeal layers because of the location of an intracerebral hematoma that's in the middle of the brain. Surgical removal is not usually possible. They have to go through a tremendous amount of brain tissue to get to those intracerebral hematomas. The severity of brain damage from head injury is going to be judged by the symptoms that the patient has, doing a neural assessment to find out the degree of insult. a history of what kind of injury happened, and how long the victim had been without consciousness or oxygen. The outward symptoms, they include bruising, swelling, lacerations, and bleeding, like we talked about. However, we don't know exactly what's going on underneath the surface. In the post-op period following a surgical intervention for a traumatic brain injury, we want to position the patient to prevent an increase in intracranial pressure. We also want to keep their neck in midline with the head of the bed about 30 degrees. We want to treat any increase in body temperature. Remember, traumatic brain injury can affect the temperature control centers of the brain. Also, we want to prevent constipation, provide good pain control, administer anticonvulsants, corticosteroids, and antibiotics per orders, and report any changes in our neurostatus. So what is increased intracranial pressure? Well, it occurs when there's a fluid accumulation that begins to take up space within the cranial cavity and causes an increase in pressure inside that cavity. Why? There's a limited amount of space and lots of things that need to be in that space. And so when you have swelling or an increase of any type of fluid, you're going to lose um, volume of something. And obviously it's not going to be the skull, so it's going to press onto the brain. Pressure against the cerebral veins and arteries will interfere with the flow of blood. So what's going to happen? Well, there's going to be ischemia and hypoxia. Signs and symptoms of ICP include lethargy, decreased consciousness, and slowing of speech and delay in verbal cues. What are we going to do for people with increased ICP? Well, we're going to provide them supportive care. We're going to put them on diuretics to decrease the volume. We're going to put them on Lasix, which is a diuretic. We're going to put them on dexamethasone or Decadron. We may put them on a ventilator and provide oxygenation. They may also get barbiturates and anti-seizure medications, and we may have to worry about their temperature control and provide interventions as necessary. Complications of increased ICP include hydrocephalus or diabetes insipidus. In regards to increased ICP, it's so important that you know that any lesion or fluid accumulation that begins to take up space within that cranial cavity will cause an increase in pressure in that cavity. We know the Monroe-Kelly doctrine. It tells us that 80% of the cranial vault is taken up by the brain, right? 10% is taken up by cerebrospinal fluid or CSF, and 10% is taken up by cerebral blood flow. So if any one of those three elements increases, we're above 100%. So our pressure is going to rise. The body will move some of the cerebrospinal fluid into the spinal dural sac. Some of the blood will end up flowing other places. Medications will be given to reduce brain swelling. Although all of these measures can help, they do not prevent increased ICP, and therefore the brain could continue to swell from injury or surgery. There could be a leaking of blood from ruptured cerebral vessels, and also excessive production of CSF or tumors, abscesses, or any other space-occupying lesion will continue to grow. And all of those things will create an increased risk for increased ICP. Okay. So speaking about um, the hydrocephalus and diabetes insipidus, right? Um, we don't want hydrocephalus to occur. That's the excessive accumulation of cerebrospinal fluid. It causes motor deficits, cranial nerve deficits, decreased cognitive ability. We can focus on eliminating or decreasing those deficits and promote as much regain of function as possible. However, sometimes the damage is permanent because damage to brain cells may cause permanent scarring or increased potential for seizures. Diabetes insipidus can occur from injury or edema to the pituitary gland. Antidiuretic hormone will be released in not enough amounts, inadequate amounts, which will result in patients that will pee a lot. They also may drink a lot, excessive thirst. We can give them IV or sub-Q vasopressin or like synthetic ADH. However, even though the IV or sub-Q vasopressin and fluid replacement is preferred treatments, um, we don't always see a total recovery of the symptoms of diabetes insipidus. We must carefully monitor I and O on these patients and their electrolyte balances. Immediately report increasing ICP. This is so important. Any symptoms of ICP are going to be so important to tell your nurse if you're a nursing student, and also your doctor if you are a nurse. Extreme restlessness or excitability following a period of calm, deepening stupor or decreasing level of consciousness, a headache that just will not go away and keeps getting worse, vomiting, especially persistent projectile vomiting, unequal pupil size, or abnormal pupillary reactions, a leakage of cerebrospinal fluid from either the nose or the ear, and any change in the patient's blood pressure, usually an increase in the blood pressure, an increase in the pulse, um, any change in respirations, a widening pulse pressure, oftentimes a systolic elevation. Um, and then, oh, excuse me, I am mistaken. It is a slow bounding pulse. So increase in the pulse pressure, decrease in the pulse rate. So please forgive me for that, for misspeaking there. What are our goals of nursing care? Well, we want to maintain cerebral perfusion. We want to make sure that all of the brain is getting blood flow. We want to reduce that intracranial pressure, right? We want to maintain adequate respirations, protect the patient from injury, maintain all normal body functions, and prevent complications. Before we move on to injuries of the spine and spinal cord, I just want to bring up a couple more important facts about head injuries. It's important that we teach the family after a patient has had a head injury not to leave that patient alone until they're back to normal. We don't want that patient to binge, strain, and perform strenuous activity as it can increase intracranial pressure. We also don't want that patient to operate machinery or drive until the healthcare provider has cleared them for that activity. The patient may complain of nausea, they may complain of headaches, difficulty concentrating, or dizziness, and those symptoms may go on for several weeks. For the first 48 hours, however, we'll watch for and report these signs, right? Worsening headache, odd behavior, seizures or weakness, any kind of clear or blood tinge drainage from the ears or nose, any changes in speech, any projectile vomiting, unusual dizziness, sleepiness, loss of balance, or falls, any change in vision or level of consciousness, like becoming more groggy or not wanting to wake up, becoming confused, restless, or agitated. There are lots of um, concerns with ICP. The big thing I want you to remember to look for is that the earliest sign of increasing ICP is that this patient is going to be lethargic and is going to have a decreased level of consciousness. They may also have a slowing of the speech and delay in the response to verbal cues. Okay. Bradycardia with a full bounding pulse, rapid or irregular respirations, rising systolic blood pressure, widening pulse pressures are late signs in increased ICP, as are the pupillary changes that can occur, and they are going to tell you that there is an absolute emergency and the patient needs to be immediately evaluated. Intervention has to be immediately taken in order to keep the patient from dying. Very important. It's really important that we don't allow these patients to become constipated or bear down doing Valsalva maneuvers. We don't have them hyperextend or rotate their head. We don't flex their hips more than 90 degrees. We don't place the patient in Trendelenburg for any reason whatsoever. And we definitely don't allow the patient to perform isometric exercises because those can increase pressure in the brain. We do want to do neurochecks at least once an hour. We want to report changes immediately. We want to maintain a patent airway, ventilate if necessary, give oxygen if necessary. Make sure the head bed is 20 to 30 degrees elevated. We want to use measures for normal body temperature because elevated body temperature can raise blood pressure, right? We don't like that. Shivering can also increase more. We want to monitor your eyes and nose and restrict fluid or fluids in disciplinary order. And also, we can do passive range of motion. We just want to make sure we space our activities apart and don't do any exercise that may increase intracranial pressure. Okay. Now, when we're assessing level of consciousness, we need to consider the following. Alert is a responsive patient that responds appropriately and attends to the surroundings. Confused is someone that's disoriented, either to the surroundings, time, or people, but their judgment may or may not be impaired. They just need to be cued. You have to tell them how to respond. Lethargic patients are drowsy, but they can be aroused easily. Um, Now, they do need gentle touch or verbal stimulation to do what you've asked them to do. An obtunded patient is very difficult to arouse. They respond very slowly to stimulation. Now, you have to repeat the stimulation in order to get any kind of attention or have them respond. Stuporous patients respond only to vigorous stimulation, and they only respond slightly. They may even moan or mutter. And then lastly, your comatose patient isn't going to have any observable response to stimulation. When we talk about older adults and brain or head injuries, we want to think about how they are at exceptional risk for damage because the brain of the older adult is more. Um, uh, it moves more, it's more freely moving inside of the cranial vault when head trauma occurs. The small vessels may be torn. So these patients are more at risk for those subdural hematomas, right? Those slow bleeds. And oftentimes our elderly patients are at um, uh, increased risk for cardiovascular incidences. So we put them on like antiplatelets or anticoagulants, Brilinta, Eliquis, and the like. Um, and when an injury does occur, that patient needs to be watched for several months. Why? Because that slow bleed that wasn't detected on the CT or wasn't noticed when we did any other kind of radiograph or imaging may end up increasingly worsening over a long period of time, especially if they're on blood thinners. Moving on to injuries of the spine and spinal cord. Okay. Etiology, injury in the cervical and lumbar areas are the most common. The amount of loss of function is going to depend, and the amount of loss of sensation is going to depend on the level that the injury occurred at and the extent of injury to the spinal cord. How affected was the actual spinal cord? Pathophysiology, well, cord injury is usually caused by some compression, pulling, twisting, or tearing of the spinal cord. Two types of injuries usually occur: a complete or an incomplete injury. So, what differentiates a complete from an incomplete injury? We're going to be looking at the amount of damage to the spinal cord. Okay. Um, Remember that any kind of a subluxation of the vertebral column can cause compression or spinal cord damage, right? Also, crash or destroy the spinal cord tissue. So, whatever the cause of injury, nerve transmission is interrupted. It may no longer occur below the level of the damage, and then you have various extensive paralysis. Here's an example of a vertical compression. Either the person has fallen, and they've got some type of compression fracture in their lumbar area, or the person is like dove or fallen headlong into something and had a compression fracture in their cervical vertebrae. What are our four main objectives for treatment? Well, we want to save the person's life. That's the big one, right? Additionally, we want to prevent any further injury to the spinal cord. We want to carefully handle the client. We want to repair as much of the damaged cord as possible. And we want to establish a routine of care that's going to improve and maintain the patient's state of health. And it's also going to prevent further complications so that eventually there will be physical, mental, and social rehabilitation. Additionally, we'll provide respiratory management, we'll immobilize, we may do surgery, we'll manage the urinary system, we will provide psychological care, we will walk the patient through or the family's patient through the grief and mourning process, even if just of a loss of function or sensation, and we will address any sexual concerns the patient may have relating to paralysis. Here's your audience response question number 2. A 40-year-old man with a T4 spinal cord injury suddenly complains of a severe headache. With increased pulse rate, sweating and flushing above the level of the spinal cord lesion, and goosebumps below the level of the injury, what would be your immediate nursing action? Select all that apply. I will give you a moment to think about your answer. Correct answer is 2, identify the cause of the stimulation, what's going on, administer antihypertensives to reduce blood pressure, and provide measures to facilitate a bowel movement to reduce intracranial pressure caused by straining. Here's an example of Crutchfield tongs, something that we use for cervical traction. A halo traction device is going to help stabilize the cervical vertebrae. Here's a rotarest. It's a bed that we use to turn the patient to balance their intracranial pressure. Complication of injuries of the spine can include spinal shock or neurogenic shock, muscle spasms, autonomic dysreflexia or hyperreflexia, orthostatic hypotension, DVT, infection, skin breakdown, renal complications, or heterotopic ossification. Before we move on from the spinal cord injuries, I want to talk about the level of injury and how much that matters. If you have a high level, like a high cervical C1 to 3, the patient may not be able to breathe on their own. So we have some serious issues. This usually is going to result in death for the patient unless there's some kind of immediate intervention. We very quickly reestablish respirations and oxygenation status with a ventilator. We may also end up um, after they've been acutely taken care of in implanting a phrenic pacemaker that will stimulate the phrenic nerve. We also can manipulate, or these patients can manipulate an electric wheelchair with their breath, their chin, or their voice if they make it through this kind of injury. Of course, they will be quadra or tetraplegic. Those words are interchangeable. At a C4 injury, we'll have a loss of diaphragm movement. They will have to have assistance to breathe. They're also tetraplegic or quadriplegic. They can live if they have assisted respirations and that we immediately intervene to provide assisted respirations. C5, they're going to have partial shoulder movement, partial elbow movement, but they will not have full movement of their upper extremities. They will be able to turn their head and feed themselves with special adaptive devices, and they will move in the wheelchair for short distances and move well with an electric wheelchair. Okay. C6 injuries, they will be able to retain the gross motor function of their arms, partial shoulder, elbow, wrist movement. They will still be tetraplegic or quadriplegic. They will need adaptive devices. They'll be able to propel their wheelchair if they have appropriate adaptive devices. They will be independent in feeding, and with some grooming help and adaptive devices, they will be able to be more independent in their ADLs. Oftentimes, they can roll over in bed and can drive a car with hand controls. They can also assist with transfers and can self-cath themselves. C7 injury, they are also tetraplegic or quadriplegic. Usually they're able to move parts of their hands, but not their full hand. These people are a lot more independent in most of their ADLs. C8, they will actually have normal arm movement, but they will have hand weakness, right? So they'll be very, very independent and be able to self-cath. T1 through 10, they're going to have normal arm movement and strength, but loss of bowel, bladder, and sexual function. They may achieve walking with braces, or they may be able to perform ADLs and achieve goals for themselves. These are paraplegic individuals. T11 and below is usually a loss of bowel, bladder, or sexual function as well. Also paraplegics. They are able to perform their ADLs more effectively, work, and participate in recreational activities. Okay, herniated discs. We're talking about back pain and ruptured intervertebral discs or slip discs, as we often heard them called. What causes them? Well, an acute lumbosacral strain will cause a slip disc. Instability of the lumbosacral spine, osteoarthritis of the spine, intervertebral disc degeneration, spinal stenosis, herniation of the intervertebral disc. And then what is going on? Well, the vertebral disc will rupture and it will compress the spinal nerves. So here's a picture of a herniated nucleus pulposus or herniated disc. What is it doing? It's compressing the spinal cord. So a lumbar herniated disc was going to cause pain that radiates down the sciatic nerve into the buttock and then down below the knee. Muscle weakness and paresthesias may occur, but a cervical herniated disc is going to cause pain in the neck and shoulder. It's going to radiate down the arm with numbness and tingling of the hand. What are some complementary and alternative therapies we can do? Well, we can always do acupuncture, especially for chronic back pain. Also, acupressure is going to help relieve muscle spasms, as well as massage therapy will do the same thing. Surgical procedures, we're talking discectomies, spinal fusion, laminectomies. And as far as nursing management, we're just going to take care of these patients during the preoperative and postoperative periods. Here's an example of log rolling. What do we need to do for patients that have low back pain or have a spinal surgery? We need to bend our knees. Um, excuse me, what do we need to educate our patients to do? We need to educate them to bend their knees with their back straight and crouch to lift an item off the floor, to carry items close to their center of gravity or the center of their body, to perform back exercises twice a day, and make sure that we're making sure that they know the correct way to perform the back exercises. We also want them to maintain an appropriate body weight. And if they need to lose weight, then we encourage them to do so. We may also encourage them to use a lumbar pillow or a roll when sitting or and particularly when driving for long distances. We may also want them to stop and walk around at least every 2 hours when they're on long trips. It's important to consider how to safely perform a task before they start to do it. What do we not want these patients to do? We don't want them to lean over. We don't want them to reach for high items or lift heavy items, to stand or sit for long periods, to sleep with their legs out straight without a pillow between under their thighs or between their legs. We don't want them to bend from the waist to pick an item up, and we don't want them to twist to the side to lift things like groceries or something in the trunk. Okay. Just a few other notes before I let you go. We want to make sure that a patient that has a loss of bladder control, checking on that bladder, we want to make sure it doesn't become overdistended. If they're on bed rest, we need to check the catheter, the drainage tube, the indwelling catheter every couple hours, so Q2 hours. When they haven't voided or we haven't got an output, um, we need to palpate the bladder for distension, maybe even do a bladder scan and let the doctor know, of course. When the patient exhibits symptoms of um, any kind of bladder distension, we need to let someone know. Some medications that we give with head and injuries include methylprednisolone or solumetrol. It's not a steroid, so it's going to decrease inflammation by suppressing leukocyte migration to the injury site. It's also going to decrease capillary permeability. We're going to give it as an IV bolus, and it may also be given as a continuous infusion. Unfortunately, it can cause insomnia, susceptibility to infection, maybe even GI distress, and it may delay wound healing. We need to watch patients we need to watch the electrolytes carefully. And we may also give them an H2 receptor blocker or a proton pump inhibitor to prevent a stress ulcer. Okay, they need to report heartburn or stomach pain right away. Baclofen is a skeletal muscle relaxant. It inhibits responses in the central nervous system by decreasing GABA, and that decreases the frequency and severity of muscle spasms. We need to make sure that these patients are not having seizure activity, that they're not weak in their muscles or over fatigued in their muscles. And we need to assess them for allergic symptoms like rash, fever, or respiratory distress. It's important to remind these patients not to drink alcohol. Why? Because it's a CNS depressant. We also don't want them to discontinue any medication quickly because it can cause issues. GABA analogs like pregabalin or Lyrica or gabapentin or Neurontin are going to help to relieve neuropathic pain. Uh, Neuropathy is a serious issue in patients with these kind of conditions. They may cause them to become kind of subdued or dizzy. They also can cause CNS depression if they're combined with opioids. Lyrica specifically can cause a prolonged INR. It's important to report any mood changes because these medications can cause depression. Also, if there's any blurred vision, muscle pain, swelling in the extremities, you need to let the doctor know. And they should not stop taking Lyrica or gabapentin or whatever abruptly. Dopamine is given. It's an adrenergic action vasoconstrictor. It acts on the alpha receptors, right? It causes vasoconstriction in the blood vessels, so it raises the blood pressure. We need to monitor vital signs closely, I&O, make sure they're on a cardiac monitor. We need to recognize this can cause nausea, vomiting, or diarrhea. We definitely have to have IV access on the patient. And then it's good, it's not, there's nothing wrong with it, because if the drug dopamine gets into the tissue, it can cause necrosis. So it's very important. Mannitol is a big one that you hear about, especially in ICU. Mannitol is an osmotic diuretic. It's going to increase the osmotic pressure, and it's going to promote diuresis. So monitor your vital signs closely, track I's and O's, assess skin turgor, make sure you're watching for signs and symptoms of dehydration, monitor these patients' electrolytes, observe them for nausea, backache, hives, chest pain, okay? And there's going to be increased urine output with this medication. So make sure that your patient knows that this is normal for mannitol. Precedex is also an ICU medication. It's a selective alpha adrenergic agonist. It also is very sedating in nature. It is given to help calm the patient, and sometimes given in preparation for any kind of procedure that we may do on the floor in ICU. Oftentimes it's administered in a continuous infusion, and we titrate it to make sure we get the appropriate effect. So they're on Precedex drips. It's not shown to cause any kind of respiratory depression, but it can cause low blood pressure or a low heart rate. So watch out for those signs and symptoms. And then propofol is given, or Diprivan. It's also a sedative agent. It also helps inhibit GABA and the function of GABA. We give this by a continuous infusion, and we titrate it for effect. Hypotension and respiratory depression can occur with the propofol. And families should know why we're giving the medication, so that they're not confused by why we're injecting things in their loved one. Okay, guys, I think that is it for this section. I highly recommend checking out the Care Clean data for this, and guidelines for patients that have low back injuries or spinal injuries. There's lots of great questions at the end of your chapter. Take care, and best of luck on your quiz.